It's my privilege to be part of this webinar, which is the first of the present committee, and from one very lively and passionate committee to another passionate committee. So it's been a wonderful journey for me to be part of both the past secretary and president to the present secretary and president. Thank you very much for this opportunity. And today's topic being so important, the importance of preoperative assessment to identify the high-risk patients, so that we not only understand what is the risk quotient in these patients, but also to plan what to monitor, how to optimize, and eventually to get a patient to get very good outcome as well as saving on hospital costs. So in all this particular topic is very, very important, and it is my privilege to introduce Dr. Madhuri Kurdi. She's professor and head of the Department of Anesthesiology, KIMS Hubli. She's been a post-PG teacher, PG examiner. She is an associate editor of IJA and assistant editor of JOACP. That speaks volumes about her. And she's been awarded many awards and rewards: ISA, IJA Best Paper Reviewer Award, ISA Proficiency Award, etc. And she has got multiple publications, and she's contributed in many chapters in books. Over to you, Dr. Madhuri.
Thank you, madam. Thank you very much for that nice introduction. So without wasting any time, a very good evening to all the ISA dignitaries, the president, the secretary, Dr. Bajwa, and the entire governing council, and all the postgraduate students who have logged in today for this webinar, and all the other my ISA colleagues. So this is a very proud moment for me that I am able to speak today for this webinar, which, as Indrani madam said, is the first webinar of the series, which will be conducted by the new ISA office bearers. So it is. I have completed 26 years in medical education, and what better podium would this be for me to celebrate this achievement? So my topic for today will be risk assessment and how to identify the high-risk surgical patient. So I'll start sharing my screen.
Yeah, please go forward.
Yes, one second. I'm just sharing my screen. Can you all see?
Yes, we can see this.
We can see.
Yes, thank you very much. So the topic of this talk today will be identification of the high-risk surgical patient. I bring you warm greetings from my institute, Karnataka Institute of Medical Sciences, Hubli. Now, look at this, I just took some screenshots from the case sheets, which are written by some of our postgraduates, or even consultants also tend to write like this. Like, after doing the pre-anesthetic evaluation, they write the instructions and the advice. On table, grave risk to be taken. Patient can be taken up for surgery with mild to moderate risk. And surgeons tend to read this and get confused. Look at this, one more example. Patient's cardiopulmonary status at the time of examination is stable. However, on-table risk assessment should be done by the operating surgeon and anesthetist, and case can be taken up for OT under high risk. So I don't know what you can make out from this. One more example. Patient can be taken up for surgery under minor risk. However, on-table risk should be taken by the operating surgery and anesthetist. So risk and risk. What is all we are, what is that we are talking about when we talk about the risk? So what is operative risk? It is nothing but a combination of physical status of a person, the expected physiological derangement by the intended surgical procedure, because every surgical procedure will not produce the same degree of physiological derangement. Then the surgeon's skill and experience is also very important. If it's an inexperienced junior surgeon, for example, a junior resident in surgery operating, definitely I would say the operative risk is going to be more compared to when the professor or the unit chief is operating. Then the availability of physiological support service in the perioperative period, perioperative optimization and critical care services. That is, if you take up the case in a peripheral remote hospital where there is no facility of a intensive care unit, then definitely if something goes wrong, the patient outcomes are not going to be good. And I would say that the risk is more in this particular patient or situation. Then the anesthetist experience with the right choice of anesthetic techniques is also very, very important. If the anesthetist chooses the wrong choice of technique or something which is not confident in, then definitely the operative risk is going to increase. So now we are going to see who is a high-risk surgical patient or how exactly to identify the risk. Now, what is the need for identifying the high-risk patient? First of all, when you know that a particular case is associated with a high risk, you get an opportunity to inform the patient about the expected risk. You can tell him that, look, this is the amount of risk and you have to come prepared for this. And sometimes the risk will be so much that the patient and his relatives and the other involved consultants, the surgeon, the anesthetist, can all get together and they can participate in what is called as shared decision making. In shared decision making, the risk is discussed, and then if the case is so risky, then the surgical procedure is deferred. The surgery will be cancelled or it will not take place, and some other conservative plan of management will be informed to the patient, and the patient will adopt that particular plan. So instead of undergoing the surgery and then having a poor outcome, the surgery doesn't take place. Then it helps to make selective referrals to medical specialists before surgery. That is, you can refer the patient. Then you can order specialized preoperative investigations and interventions if the case is risky. And you can select surgical and anesthetic personnel of appropriate seniority. Now, when the case is having a high risk, definitely the senior surgeon is going to operate and the senior anesthesiologist is going to anesthetize the case. Then, for the initiation of alternative non-operative, I already told you this. Physiological complications. This is very, very important. When you know the risk, you know that you have to optimize the patient's physiological status. You buy time to optimize physiological status, and by optimization or what is called as prehabilitation, what you can do is you can reduce complications and thereby improve the post-operative outcomes. Then to allocate expensive monitoring and intervention. Now you need not apply all the rare and expensive, costly monitoring devices for all the patients. Accepting the minimum mandatory monitoring, you will not use the other devices for all cases. So if the case, depending on the risk, you can use your monitoring devices. And it can guide regarding the level of post-operative care needed. So you know that if this case is risky, you're going to keep an intensive care unit bed ready for your patient. Now, how this identification should be? One thing is it should be accurate, it should be timely, and it should be done early. There is no point in identifying the case late. So there is no point in crying over spilt milk. Once the case is spoiled, or once the outcome has already become poor, then you cannot do anything. You should have been more smart and identified the problem or the risk much earlier than you could have decided, or you could have planned on your interventions in a better way. So it has to be accurate, it has to be timely, and it has to be done early. Now, when should this risk assessment be done? Well, it can be done pre-operatively, it can be done intraoperatively, and it can be done immediate post-operatively also. Most of us, we do it pre-operatively, but there are some scores which I'm going to tell you shortly, where intraoperative variables and immediate post-operative parameters are also taken into consideration. Now, how to do the risk identification? There are various risk prediction tools, and these include various scores and risk prediction models. Now, these risk prediction, how you do is, you can do it mainly by clinical evaluation. And by clinical evaluation, the tools include various indices like the RCRI. I will explain everything what are these in the later part of my talk. The Revised Cardiac Risk Index, the ASA Physical Status Classification, the Duke Activity Status Index, the American College of Surgeons National Surgical Quality Improvement Program calculator, then the POSSUM, ESAS, and so many others. Then complementary to clinical evaluation, you have tests like the cardiopulmonary exercise testing. Then you can estimate biomarkers and frailty and so many others. So these scores can be classified depending upon whether they are predicting mortality or whether they are predicting morbidity. Then there are scores which do not require operative information, and there are scores which require operative information. So the American Society of Anesthesiologists physical status classification, all of us know that it predicts both mortality, morbidity, does not require any operative info. Whereas there are some like the POSSUM, the POSSUM, the surgical Apgar score, the Mannheim peritonitis index, these require operative info, and they predict both, some of them predict morbidity and mortality, and some of them predict only the mortality. So there are some risk tools which can be used in emergency cases and some which can be used in non-emergency cases. In emergency cases, you can use the ESAS, the PSAS, the ACS, NSQIP, ASA, and the Lee's Revised Cardiac Risk Index. Non-emergency risk tools are again the ASAP physical status, the Lee's Revised Cardiac Risk Index, POSSUM, surgical Apgar score, and the ACS, NSQIP. Now, what are the patient factors which will help you to identify the high-risk patient? Most important is age, gender, and the physiological reserve. Old age, neonates, and males are supposed to be high-risk cases, or the risk is more in these particular patients. Then comes presence of comorbidity. All comorbidities, the risk increases, but more so in the presence of liver cirrhosis, ischemic heart disease, and malignancies. Then, one very important point to remember when you assess the risk is the preoperative albumin level of the patient. Please remember that lesser the albumin level, higher the risk, because hypoalbuminemia increases the risk of infections and the length of hospital stay. It is well proven. There are so many studies and meta-analysis which have proved that, and clinical experience also tells that hypoalbuminemia can increase the hospital stay. Then, of course, there are minor patient factors, patient with history of obstructive sleep apnea, you can elicit it by the stop bank questionnaire, history of previous surgery and anesthesia where they had problems with airway management, history of adverse reactions to anesthesia, history of prolonged apnea in the previous anesthesia experience, difficult IV access, malignant hypothermia, then nowadays history of addiction, drug use. All this, if it is there, definitely the patient is risky. Now, there are some surgical factors which decide the risk of the grade of risk. So, low risk surgery means the risk will be less than 1%, and this is applicable to superficial surgeries, breast surgery, dental, endocrine surgeries like the thyroid, minor gynecological surgeries, minor orthopedic surgeries, and minor urological surgeries, and reconstructive or plastic surgeries. So here the risk is very, very less. It is less than 1%. This also includes endoscopic procedures, cataract, everything comes here. Then comes the intermediate risk surgery, 1 to 5%, included in intraperitoneal, carotid, symptomatic carotid cases, intrathoracic minor surgeries, endovascular aneurysm repair, head and neck surgery, major orthopedic cases, neurological, gynecological or urological procedures, and renal transplant. And high risk surgery means risk is more than 5%. It is seen in cases like pulmonary or liver transplant, total cystectomy, duodeno-pancreatic surgery, liver resection, bile duct surgery, esophagectomy, perforated bowels repair, pneumonectomy, and adrenal resection. Now, all this may not be new to you because this is given in Miller, Barash, and our textbooks, but it is my duty to revise this now since the topic is on risk. Now, this is just the same thing which I have put it in the separate slides. Now, let us come to our evergreen physical status classification, that is the ASA, the American Society of Anesthesiologists Physical Status Classification. All of us know about this ASA grading. I think the postgraduate student, once he joins the course, within 1 or 2 days only, this word, it just sets in his mouth and in his mind and in his brain, and it remains till he dies as an anesthesiologist. So I don't think there is any anesthesiologist in the world who doesn't know about this ASA physical status classification. So just to revise, it was introduced in 1941 by Saklad and modified by Drips in 1961. And what does it indicate? We often say ASA grade this much, ASA grade. Do we know what you exactly mean by the ASA physical status? Well, it indicates a patient's preoperative fitness. It provides a metric, a number for communicating with colleagues. Like you can tell the surgeon also, look, this patient is ASA grade 4. So he knows what you mean by that it is a high risk case. It provides a stratification system for research. Now, when you do research studies, say whether it's an observational study or a randomized controlled trial or whatever, we tend to select our patient population for the research. So we recruit patients from a particular ASA grade to maintain uniformity. So most of the studies, we will select patients from ASA grade 1 and ASA grade 2. And of course, it's not a hard and fast. We also do it in ASA grade 3 and 4. But it is my observation that most of the studies are done in ASA grade 1 and 2. Then it denotes, the ASA grading also tells you how sick the patient is in the preoperative period. So this is just a revision of the ASA grading. ASA grade 1 is a normal healthy patient. ASA grade 2 is with mild systemic disease. 3 is severe systemic disease. 4 is severe systemic disease that is a threat to the life. 5 is a moribund patient who's not expected to survive without the operation. And 6 is a brain dead declared patient whose organs are being removed for donation. And when you use this terminology, you should know what exactly, which type of cases are included in this particular grade. So ASA grade 6 is very easy to remember. 5 also okay and 1 also okay. The confusion lies between 2, 3 and 4 borderline. So you should understand this well. So the predicted risk of mortality after major surgery performed as urgent or emergency, if you see this, you see the ASA class on one side and the age on one side. So as the age increases and the ASA grading increases, the mortality risk also increases. The predicted risk of mortality increases. If you see this, age more than 70 years and ASA grade 4, see the risk is 56.8%, whereas less than 50 years and ASA grade class 1, it is only 1.6%. So this is how the age and the ASA class, they are related. So this ASA physical status classification has several merits. It's a very simple system, very easy to communicate and low cost. And it has an independent association with the postoperative morbidity, mortality, and readmissions. But there are several demerits also. It is said to over-predict the mortality risk. And the term systemic, when we say systemic disease in SA, it introduces subjectivity. It does not take into consideration surgical risk factors, the complex nature of the surgery, the blood loss. It does not take anesthesia factors, like positioning, difficult airway, aspiration risk, all those consideration. So on its own, it cannot be a sole predictor of operative risk or perioperative mortality and morbidity. Now, if you have to assess the cardiac risk in non-cardiac surgery, MACE means major adverse cardiac events in non-cardiac surgery, you can use risk indices like the revised cardiac risk index, the ACS-LS-QIP, or the Gupta's NICA calculator. And then, of course, you have various methods to assess the functional capacity, and this can be done using METs, cardiopulmonary exercise testing, Duke activity status index, and the incremental shuttle walk test. Then, of course, you have to do the 12-lead ECG in the last 3 months. That is important. If the patient has dyspnea, left ventricular function assessment is important. If the METs is less than 4, then you have to go in for a stress testing and coronary angiography, of course, in case of transplantation cases. Biomarkers are also very important. Now, the cardiac risk assessment for non-cardiac surgery, there are several indices. Lee's revised cardiac index is the latest one and the most commonly used one. There were some old ones like the Goldman, the Detsky, and the Eagle cardiac risk index. You will see this in textbooks, but now the recent textbooks have knocked off some of these old indices. So just to show them, Goldman in 1977, there were several criteria, parameters there. Detsky in 1986 and Eagle in 1989. Yeah. So coming to the revised cardiac risk index. Coming to the revised cardiac risk index, this was developed in 1999 by Lee et al. Of Brigham and Women's Hospital. And this RCRI, it predicts major cardiac events after non-cardiac surgery. See, these are the various criteria in the Lee's revised cardiac risk index. So when you're asked in the exam or even every day when you go for pre-anesthesia assessment, you must calculate this Lee's revised cardiac risk index. So a question out to the postgraduates here. Are you using the Lee's revised cardiac risk index here? How many of you are using? Just raise your hands. Raise your hands, I can see them. Only 2 of you? Very encouraging. Please raise. Nobody's going to scold you. It's a good index. It can be used. Okay, fine. So just to revise, the parameters include the high-risk surgery, which is defined as intraperitoneal, intrathoracic, or suprainguinal vascular surgery. Presence of coronary artery disease, and how it is defined also, there are specific points in that. Yes, no. Then, of course, the presence of congenital congestive heart failure. Yes, no. And cerebrovascular disease, defined as history of transient ischemic attack or stroke. Yes, no. Diabetes mellitus more than 2 milligram per deciliter. Yes, no. So these are the various criteria, and 1 point is attached to each of these criteria. Major cardiac complications increases with the number of risk factors. So you see that. Points. In the Lee's revised cardiac risk index, the points increases. Say it is more than 3, then it becomes 4, and the cardiac risk increases from 0.4% to 11%. So this is how you estimate the risk by the RCRI. So the end point of RCRI is the occurrence of primary cardiac death or any cardiac complication such as myocardial infarction, pulmonary edema, ventricular fibrillation, and complete heart block. What are the merits of the revised cardiac risk index? Where it is less subjective than ASA grading. It is a very simple validated index. It is easy to use. But there are demerits that does not accurately predict an individual patient's absolute risk of cardiac complications, and it has limited validity for non-cardiac outcomes, and it could include better prognostic factors like age, functional capacity, which are not included. Now, this is an exercise for the postgraduates. A 46-year-old male patient presenting to the emergency room with symptoms of sudden onset severe headache and left-sided weakness. Non-contrast CT scan shows a right-sided subdural hematoma, and his medical history was significant for myocardial infarction 2 years ago. So what is the revised cardiac risk index of this patient? Who can tell me? 1, option A 1, option B 2, option 3, C is 3, and option D is 4. Please put your option in the chat box.
We have got one answer, 2.
Only one. There are so many postgraduates. Please tell, don't get. If you want, I can put up once more. I will put for you to revise. Diabetes mellitus, serum creatinine, congestive heart failure, cerebral vascular disease, high risk surgery, coronary artery disease. So just find out what is there in this particular case. There is history of MI 2 years back. Other than that, there is nothing. So what is the answer? Now coming to the preoperative resting echo. It provides prognostic information on cardiac function, ventricular systolic and diastolic function. It tells you about valvular abnormalities, fixed wall motion abnormalities, and pulmonary hypertension. This question is very common asked in the PG exams. Okay, what information does 2D echo give you, right? Now comes the functional capacity assessment. This is very, very important, preoperative. How you're going to do it? You can do it subjectively by using METs. I'll tell you what is METs. Objectively using cardiopulmonary exercise testing and C and ISWT. But please remember that cardiopulmonary exercise testing is the gold standard for the assessment of functional capacity. Now comes METs. What is METs? It is nothing but metabolic equivalents. It is a self-reporting of daily activities of the person, and it gives us a correlation with perioperative events. One MET. This question is very often asked in the exams, and you should be knowing that what is the definition of one MET? One MET is defined as the basal oxygen consumption of a 40-year-old and 70 kg man in the sitting position, and it is equal to 3.5 ml per kg per minute. So if you say one MET, means when you say that, suppose a person says, how much of what work do you do? Are you able to work? Can you play? All these questions you have to ask. So the patient can move around in the house and just walk 1 to 2 blocks on level ground. It becomes less than 4 METs. We can do light housework, moderate recreational activities. It is 4 to 10 METs.
Dr. Madhuri, unmute yourself. I've muted all. Unmute yourself. Dr. Madhuri, unmute yourself. Dr. Madhuri, unmute yourself.
I have unmuted myself.
Yeah, fine. Fine is fine
Can
now.
you hear? Where were you not able to hear me?
Just two slides back. Just two slides back.
But I'm not able to move ahead. I don't know what happened.
Okay.
Correct. So if the METs is less than 3, please remember that the functional status is poor. If it is 4 to 6, it is moderate functional status. 7 to 10, it is good functional status. And more than 10 METs means excellent. For the benefit of those who I think I was muted that time. So I just once more I'll revise. 1 MET to 3 METs is self-care. The patient is able to move around in the house and walk 1 to 2 blocks on level ground. 4 to 10 METs is the person can do light housework, heavy housework, and moderate activities like playing doubles tennis and running a short distance. And more than 10 METs is strenuous sports like swimming, football, basketball, and so on. And please remember, this part is very, very important, that patients with METs more than 4, the risk is definitely less. You need not investigate them further. But patients with METs less than 4, please remember that you have to further evaluate them. This is very, very important. This I have already told you. Now comes the 6-minute walk test. The 6 became very common during COVID. So what does it do? It measures the distance walked over 6 minutes. It is a very quick, simple, low-cost measurement of the functional capacity. Even very frail and elderly people, you can make them to do the 6-minute walk test. And there are equations that predict the distance that a patient should walk based on his height, weight, age, and gender. Please remember that it is not that how much distance I am supposed to walk, the same distance Amitabh Bachchan can walk, right? So his height is different, my height is different, weight also, everything matters. So there are equations that predict the distance. The 6-minute walk test calculator is available. You can use these. I'll just click on this and I'll show you. This is how the walk test is available. This is the 6-minute walk test calculator. I have connected to the Wi-Fi. So we need to start by calculating the 6-minute walk test predicted distance. This is the formula using height, age, and weight. So this is how you calculate. And then you have to see, once the answer you get, find out if this result falls into the 6-minute walk test norm. Okay, and finally, we can calculate the percentage our patient managed compared to the expected distance of a healthy patient. So when you are free, once you go home today, once you are free, sorry, you are at home, I suppose. So you can just log into this and find out what is this calculator. Now comes the cardiopulmonary exercise testing. This is popular in England as a specialized test for pre-operative risk assessment. What is done in CPET? CPET often comes as a short note, and it is a new thing which is coming up. The subject is exposed to incremental physical exercises up to a maximally tolerated level by using an exercise bicycle, also known as a cycle ergometer, or a treadmill. And the work rate is gradually increased in a stepped manner until the subject is not able to continue any further. The optimal duration of exercise will be 10 minutes. And what is recorded in this? Physiological variables that are recorded include ventilatory parameters, inspiratory and expiratory gases, blood pressure, and the electrocardiogram. And two more important function parameters which are measured here are the oxygen uptake and the CO2 extrusion at the mouth. I'll tell you what it is. So this is how it is done. This is the bicycle ergometer. See, this, the ECG leads are attached. This person is doing the recordings. And here in this mask, here you're going to estimate the gases. So the two key indicators derived in this test are the body's maximum oxygen uptake, known as the VO2 max, and the VAT. This is very important. The point at which anaerobic metabolism exceeds aerobic metabolism, and this point is known as the ventilatory anaerobic threshold. Please remember this, the VAT and the VO2 max. What do these two values indicate? They indicate the ability of the cardiovascular system to deliver oxygen to the peripheral tissues and the ability of the tissues to use that oxygen. So it is not just the delivery of oxygen to the tissues, but how well the tissues are able to make use of the delivered oxygen. So suppose the person is not able to exercise at all, or if the low and the anaerobic threshold, which I was telling you, where VAT is less than 11 ml per kg per minute, or inability to achieve a peak oxygen consumption of 15 ml of oxygen per kg per minute, they predict an increased risk of post-operative mortality. Now I will show you a video on a very short video on cardiopulmonary exercise testing, because most of us will not have seen this. So I'll just put it in. testing is done, but the test, it has got some limitations. It is not, the research has still to take place on this particular modality. It is costly and it is resource heavy. Now comes the Duke Activity Status Index, or DASI, as I was telling you. It is a self-administered clinical questionnaire that measures a patient's functional capacity. So this is the questionnaire. It includes 12 questions like, can you take care of yourself, like eating, dressing, bathing, can you walk indoors, and so on. Questions like, can you participate in strenuous sports, and so on. And if it is yes, then so many points, 2.75, like that, 5.5, and no means 0. So how you interpret it? It can give you a rough estimate of the patient's peak oxygen uptake. So how you get a Duke Activity Status Index? Whatever sum of the, you get a sum of all this yes replies. And once you get it, the VO2 peak will be nothing but 0.43 multiplied by this figure plus 9.6. And this figure, what you get, if you divide by 3.5, you'll get the number of meds. So this particular DASI, it shows good correlation with maximum oxygen consumption on cardiopulmonary exercise testing, but it is said to have poor negative predictive value, as it incorrectly classifies a large proportion of patients as having a low functional residual capacity. Now comes the incremental shuttle walk test. It is a very simple, valid, reliable, and safe test. So what is done in this test? The person is made to walk at progressively faster pace every minute, achieved by pre-recorded signals. And the test is ended when the subject is too breathless to maintain rapid speed, or when he fails to complete the shuttle increment time. And what is recorded here? The blood pressure, the respiratory rate, the pulse rate, the dyspnea scale, and the rated perceived exertion scale is recorded at baseline and after the test. It correlates more strongly with the maximal oxygen uptake than the 6-minute walk test. And it is very useful in persons with heart, lung disease, rheumatoid arthritis, cancer, and limb claudication. So I'll just show you one video of this incremental shuttle walk test. See now. Sorry, that's not English. It's a different language, but this was the best video which I could get for you.
Starting stage 1 in 4, 3, 2, 1.
This is the pointer, as you can see. So she goes from this point to this point, and her pace has to go on increasing, and this person is doing all the recordings. What is recorded? I hope you remember what I told you.
Stage 2.
So this thing goes on till the person is not able to increase her speed. See how the speed is increasing now, right?
Stage 7.
See how the speed is increasing. Okay, so that was the incremental shuttle walk test. Now comes the cardiac stress testing. It is done when, I already told you this, whenever the meds is less than 4, you have to be very worried about this particular patient and you have to subject him or her to stress testing. Now, stress testing can be either physical stress testing or it can be pharmacological testing where a vasopressor is injected and the heart is challenged pharmacologically or given stress through drugs. Cardiac stress imaging, once you do this, give this physical exercise or a pharmacological drug is given. Next is to image the heart. This you can do with the help of echocardiography, or you can use myocardial perfusion imaging in the form of PET scanning. So what is seen in this? When you do cardiac stress imaging, if you can see reversible defects on cardiac stress imaging, this indicates increased preoperative cardiac risk and greater events of reversibility are associated with progressively increasing risk. Whereas if you see isolated fixed defects on cardiac stress imaging, then they are definitely safer and they are not predictive of increased perioperative risk. So you can see these over here. The reversible defects and the isolated fixed defects. Now comes the biomarkers. Well, now is the era of biomarkers. Not only now, but previously also biomarkers have been used in almost every branch of science. They're used to improve the risk stratification. And the preoperative and immediate postoperative concentration level of biomarkers can be used to predict myocardial infarction and death at 30 days after non-cardiac surgery. Now, which are these biomarkers which are useful for risk prediction? They are natriuretic peptides, troponins, and C-reactive protein. Most common are the natriuretic peptides and the troponins. That's why I have put this a little far away from these two. Now comes the natriuretic peptides. We have the B-type natriuretic peptide and the N-terminal pro-BNP. Values of at least 300 microgram per liter of NT-proBNP and at least 92 microgram per liter of BNP are the accepted thresholds which are associated with increased risk of death or non-fatal MI within 30 days of non-cardiac surgery. Coming to cardiac troponin, you know troponin is a very important biomarker. It is released in response to myocardial injury. And the elevated postoperative troponins in the first 3 days after surgery is significantly associated with 30-day mortality. There are a lot of studies which are being conducted on the level of troponins postoperative and their association with the mortality, postoperative mortality. And please remember, there are many cases where we have encountered where there is postoperative myocardial infarction and death occurs, but the patient will not have any chest pain or dyspnea. We have seen many such cases. The surgeon may often tell, yeah, correct, there was no chest pain, patient didn't complain of any chest pain, no dyspnea, but he went into arrest. So routine early postoperative monitoring for troponin elevation, they say, is useful to identify patients at risk of postoperative mortality. But I told you, research is being conducted on this, and I advise all of you to go into this, really find out if this needs to, if can detect mortality. Now comes the one more risk calculator, the American College of Surgeons National Surgical Quality Improvement Program. Now, this is a web-based calculator. This is based on machine learning tools or artificial intelligence. It is a web-based calculator which is available on this particular URL. It is developed by the American College of Surgeons and it is an online resource or a web-based tool. This is available you have your mobile with you. So wherever you or when you're connected to the Wi-Fi, you can just log into this and find out what is the ACS NSQIP risk level in your particular patient. Now I will give you an example. I will do it. I'm going to log into this now. Just give me a little time. It takes a little bit of time to log in. I will show you. Yes, it's come. So this is the welcome to the ACS NSQIP surgical risk calculator. So here we have to enter the preoperative information about your patient to provide estimates about the postoperative risk. Wait for the next thing to come. Yeah. So here you have to write what is the procedure or the CPT code for this procedure. There is something called as a CPT code. So suppose I write, say, cholecystectomy. Cholecystectomy. Okay. Say I write laparoscopic surgical cholecystectomy. Fine. Now, I'm going to are there any other options? None. So I'm just putting it, roughly age 75 to 84 years, partially dependent, healthy, no, not healthy patient, severe systemic disease, steroid use, no, ascites within 30 days prior to surgery, no, systemic sepsis within 48 prior to surgery, no, ventilator dependent, no, disseminated cancer, say yes, diabetes, insulin, hypertension, yes, congestive heart failure, no. I'm just putting roughly, current smoker, yes, COPD, yes, okay. And the BMI calculation, suppose I put the height as, say, 60 and the weight as 120 pounds. And now I continue. Let me see what value comes now. I'm just showing this as an exercise to you, and you can do it afterwards when you want to apply it to the patient. Just give me a few seconds, it will come. Yeah. Would you like to add geriatric outcomes? Yes, my patient is old. Mobility, original status, not from home, hospice. Oh shit. Okay. Dementia, cognitive impairment, yes. Surrogate sign. All history, no. Okay, so continue. Okay, so now I'm going to get the score now. My risk calculation is nearly over, and I'm going to get the risk score. So this is all running on machine learning and artificial intelligence, because now is the era of artificial intelligence. The robot, continue. Oh, there was some interruption. I just want to be successful in calculating the risk. Yeah, here it comes. My record is ready. Outcome. Serious complication. My risk is 12.6%. My risk means risk in my patient, 12.6. Any pneumonia, 4.4%. Cardiac complication, 1.4. Surgical site infection, 2.2. Urinary tract infection, 2.2. Venous thromboembolism is only 0.5. Renal failure, 0.6. Readmission, 18.7%. Return to OR, 1.3%. Death, 5.9. Discharge to rehab is 28.6 and sepsis is 2.3. Predicted length of hospital stay is 2 days. Post-op, now since I had entered that it is a geriatric outcome also, I wanted, so post-operative delirium, my chance is 26.1%. Functional decline is 0.9%. New worsening pressure ulcer is 1%. Surgeon adjustment of risk is there. I mean, sometimes if the surgeon can also, he can adjust the estimated risk if he feels that the calculated risk is underestimated. So if I don't want any adjustment, I can write that no adjustment is necessary and I will continue. So this is how the ACS NSQIP risk is calculated. Okay. So I'll get my final risk report and then I will go on to the next slide. Yeah, this is my report. Okay. So now I'm going to finish and I go on to my next thing. So this is all about I hope you have all understood, all the postgraduates here, how to calculate the ACS and SQIP risk. It's actually fun to calculate. So these are the various factors. I'm not going to tell them again. These were all included in that: the age, the gender, the function status, ASA grade, steroid use, ascites, system sepsis, ventilator dependence, cancer, dialysis, ARF, dyspnea, hypertension. There are 21 preoperative factors which are to be taken into consideration. So what is the outcome? The cardiac arrest, MI, and all-cause mortality in 30 days. Merits of ACS and SQIP, it has got moderate to good accuracy, and it provides a common language of communication. It is universal. It is based on all organ systems, remember. It can be used for auditing, and it has been validated in the general population, and it is freely available on the web. You don't have to pay for this. Limitations, you need the internet. So if you are in a place where there is no connection to Wi-Fi, you cannot use it. And please remember that the American Heart Association and the American College of Cardiology, they consider this calculator as the best estimate of, they provide the best estimate of surgery-specific risk of major adverse cardiac events or death. This is the Gupta's MECA risk calculator. Again, it is devised by P.K. Gupta, Gupta H. and Sundaram et al. In 2011. It is a web-based calculator. It is available on this particular URL. This is the one. See, Pratik K. Gupta is the creator of this. Gupta perioperative risk. Very easy it is. You have to consider the age, functional status, ASA class, creatinine level, and the type of procedure. Okay, so there are so many procedures here. You can choose. And then you can find out the result. Okay. Now I'm not going to fill over here and spend time. You can try this out. Okay. So then now I go to the next one. This is what was the Gupta's calculator. Functional status to revise: age, ASA class, functional status, creatinine, and the type of procedure. Outcome is the intraoperative peri-op MI or cardiac arrest in 30 days. And how cardiac arrest is defined and how MI is defined, that is also very important here. It has improved discrimination over the revised cardiac risk index. Limitations, it has no validity in population outside the NSQIP zone. And the definition of MI is restricted, that it only considers ST segment elevation or a large increase in the level of troponin in symptomatic patients. And please remember that ASA grading is included in this particular MECA risk calculator, and ASA classification, you know, has got poor inter-rater reliability. Now comes the identification of risk for post-operative pulmonary complications. We call them as PPCs. So with this question, this is very important. You should know that when you get a patient, you should ask yourself, is this patient at a risk of post-operative pulmonary complications? So how will you identify? Any patient who is with age more than 60 years, who has COPD, congestive heart failure, then with a high ASA classification, physical status classification, prolonged duration of surgery, the type of surgery, if it is high risk, especially head and neck, thoracic or upper abdominal vascular surgery, and if it's planned for general anesthesia, especially with an endotracheal tube, please remember that the risk for post-operative pulmonary complications is high in this case. So there are various pulmonary function tests, which I'm not going to tell you now, and many of them I've already described. But these bedside pulmonary function tests are very useful in that you can predict the risk with the help of these bedside PFTs. So, this test, all of you will be doing, I'm sure, when you go for the pre-anesthetic evaluation, the Sabrase's breath holding test. So when, I'm not going to explain how you do it because I'm sure all of you know how to do it. So if it is more than 25 seconds breath holding, that means the cardiopulmonary reserve is normal. And if it is less than 15 seconds, that means the cardiopulmonary reserve is very poor and you have to think if you have to take this patient for elective surgery. Now comes the Schneider's match blowing test. What does it do? It measures the maximum breathing capacity. You know, the person is made to blow a matchstick from a distance of 15 centimeters with mouth wide open, tongue protruded out, chin rested, no pulse slipping, no head movement, no air movement should be there in the room. That is, the fan should be off, and mouth and match have to be at the same level. So if he cannot blow out a match, that means his maximum breathing capacity is less than 60 liters per minute, and his FEV1 is less than 1.6 liters. And if he is able to blow out a match, that means his MBC is more than 60 liters per minute. Now, there is one more cough test, the Green and Barrow-Waits cough test, which through which you find out the patient's ability to cough, the strength of the cough, and how effective the cough is. So if the cough is inadequate, the FPC is less than 20 ml per kg, FEV1 less than 15 ml per kg, and the PFR will be less, that is the peak expiratory flow rate, will be less than 200 liters per minute. Then we have the forced expiratory time, FET, where you take a deep breath, exhale maximally and forcefully, and keep your breath over the trachea and listen. So the normal forced expiratory time is 3 to 5 seconds. It is more than 6 means in an obstructive lung disease. Then you have the single breath count. Normal count is 30 to 40. This is the right peak flow meter. Peak expiratory flow rate, please remember it differs according to the gender. Males, it is up to 700 liters per minute. Females, up to 500. This is the peak flow meter. It measures the ability to exhale, and it varies with the lung capacity, and you can monitor the lung function with it. The right respirometer, you must have seen this, all of you. It directly measures the minute volume, and you can calculate the tidal volume once you calculate the minute volume. It is a compact, light, and portable instrument. You can connect it anywhere, even in the ICU. You can connect it to the endotracheal tube or the face mask. But it underreads at low flow rates and overreads at high flow rates. Then nowadays you get microspirometers which measure the FEV1 and the FPC, and you get bedside pulse oximetry, of course, is there, and you can do an ABG analysis. So how do the preoperative PFTs help in predicting post-operative pulmonary complications? Well, if the FEV1, please remember this, is less than 1 liter, you can advise arterial blood gas analysis. Now, once you do the ABG analysis, if the FEV1 is less than 1 liter and the PaCO2 and PaO2 are normal, then please remember that the post-operative course is likely to be normal. But if the FEV1 is less than 1 liter and the PaO2 is low with the normal PaCO2, this patient is likely to require prolonged oxygen therapy. Now, if the FEV1 is less than 1 liter with a high PaCO2 and low PaO2, this patient is likely to require post-operative ventilatory support. So PaCO2 more than 45 is a strong risk factor for PPCs, and PaCO2 more than 50, patient is definitely going to require post-operative ventilation after major surgery. And please remember this, that if FEV1 is less than 1 liter, PFR less than 120 liters per minute, and FEV1 by FPC less than 40%, then there is going to be a need for post-operative ventilation, and you should keep the ICU bed with a mechanical ventilator ready for your patient. This is one more score for post-operative pulmonary complications, the ARISCAT model. So it includes various predictors like age, pre-op SpO2, pre-op hemoglobin, the type of incision, whether it is upper abdominal or intrathoracic, the duration of surgery, and the emergent nature of the procedure. So it classifies the risk. Low risk PPC rate is 1.6%, and high risk is more than equal to 45 points. The rate of post-operative pulmonary complications is very high in this case. It is 42.1%. This is one more respiratory failure risk index, the Arozula respiratory failure risk index. Again, there are several predictors here: the age, history of COPD, partially or fully dependent functional status, blood urea nitrogen, albumin, neck surgery, the site of surgery, thoracic, and of course the urgency of the surgery. So these are the various categories of risk: class 1, 2, 3, 4, 5. Class 5 is more than 40 points, and the PPC rate here is very high. Look at it, it is around 26.6%. Then, of course, we have the POSSUM scoring systems. I do not know whether you have heard of these, the POSSUM scoring systems, and this is even there in the surgery textbooks, POSSUM. And you will find surgery PGs also doing research and all and applying the POSSUM score. So it is POSSUM means what? It's a physiological and operative severity score for the enumeration of mortality and morbidity. POSSUM includes 12 acute physiological factors and 6 operative variables. So it includes 12 physiological factors which are recorded pre-operatively and 6 variables which are recorded post-operatively. So it is not just physiological, it is physiological plus operative variables. So look at this. These are the parameters which are seen in the POSSUM. The age, cardiac condition, failure, patient on diuretic, digoxin, peripheral edema, JVP raised, respiratory, presence of dyspnea and the grade of dyspnea, then the blood pressure, heart rate readings, Glasgow coma score, hemoglobin level, WBC count, blood urea, nitrogen, sodium, potassium level, and the ECG, if you can see it is normal or you can see any abnormal rhythms in the ECG. Then the operative parameters include the operative severity, whether it's a minor, moderate, or major surgery, the number of procedures, whether it is a for one procedure or 2 procedures or more than 2 is being done, the estimated blood loss in ml, the peritoneal soiling, whether that this soiling is with serous fluid, for example, it is a serous cystadenoma of the ovary, local pus, for example, in a abscess, free bowel content, pus or blood in an intestinal obstruction. Then presence of malignancy, primary only, lymph node metastasis and distant metastasis, and the mode of surgery, whether it is emergency or non-emergency. These are the operative parameters in the POSSUM. So remember, POSSUM includes physiological parameters and operative parameters. And then how do you calculate? You have to calculate the mortality risk R1 and the morbidity risk R2 by applying the POSSUM equation. This is the POSSUM equation by which you can calculate the R1 and the R2, that is the mortality risk and the morbidity risk. So POSSUM is the most widely validated and precise perioperative risk predictor which is currently utilized, but it has several demerits, that it has no validation for pre-op risk production, because you note that you have to apply the post-operative, immediate post-operative and intraoperative variables are also to be applied, and it requires considerable resources. It is not as simple and easy and using less number of resources as ASA and all those grading systems. Then we have something called as a P-POSSUM, which was developed following studies that POSSUM over-predicted the mortality. It uses the same variables as POSSUM, but with a modified regression equation. See now, this I'm giving you an exercise for all the postgraduates who are sleeping or who are planning to sleep. So here is a 64-year-old male diagnosed to have a left inguinal hernia, posted for mesh plasty. He's a known case of hypertension since 8 years. He's on tab telmisartan 40 milligrams. He complains of dyspnea on exertion. On examination, pulse rate is 78 beats per minute. Blood pressure 140/90. Investigations, hemoglobin 13.9. Total WBC count 5,400. Urea level 54. Creatinine 1.2. Sodium 138. Potassium 4.2. Dear PGs, please calculate the POSSUM operative severity score. Your time starts now. Option is 4, 2, 7, 9. Please calculate the POSSUM score over here. If you want to see the parameters, I will once more go back and I will show you. This is it. Physiological parameters, age, cardiac failure, dyspnea, blood pressure. You see the range of blood pressure, heart rate, Glasgow coma score, urea, WBC count, sodium, potassium, ECG. Everything is mentioned in the exercise which I gave you. And the type of procedure is also mentioned here. Whoever has come out with the answer, please mention in the chat box. I will send you a gift by post. Let me see who gives the right answer.
That's a wonderful incentive.
But not to the, I'll give only to the postgraduate.
Only the postgraduate
can answer. I cannot see the chat box.
Right now, there are no answers. Probably they are calculating.
Acha, let them calculate then. Shall I give them 1 minute with the permission of the chairpersons?
Yes, yes, no problem.
Okay, madam.
Everybody is really praising in the chat box about the deliberation and the way you are explaining. There are so many
Yeah.
messages in the chat
Let
box.
them calculate now. They should not sleep now. From tomorrow, they're going to apply all this when they go to do pre-anesthetic evaluation. See, the patient is posted for inguinal hernia. Blood pressure is 140/90. Urea creatinine, they are nearly normal. Sodium potassium also nearly normal. Total count is normal. Hemoglobin is normal. Patient is a hypertensive on telmisartan. And he is posted for mesh plasty. As soon as the answer comes, I will go to the next slide. Otherwise,
One answer has come, B, 2.
B2. Now let me explain. But that person has to explain how he or she got it. It cannot be just by chance. Okay. So I'll explain how you got it. The age is, what is the age of the patient here? 64 years old. So 64 comes in 61 to 70 years. So it comes to age 2 points. Next one. The patient has signs of COPD if you observe. See, patient has dyspnea on exertion and you can consider probably. Okay. Then we have shortness of breath on exertion. So this is one more point because of which you get 2 points more. Then the systolic blood pressure. Again, he got 2 points here because the patient's blood pressure is 140/90. So it comes here, 140/90 comes in this range. So now how much? And then if you come to that was what I told you was the physiological score. So 2 plus 2 plus 2 makes it 6. And now I go to the operative score. What is the points here? It's only 1 point because the patient is posted for hernia, mesh plasty. Risk is very less, 1 point. So total 6 physiological scores and 1 operative. So my POSSUM score comes to 7. That is the answer. Okay, but still I'm happy that they made an attempt at calculating it. So even I found difficulty when I tried to calculate initially, but now I'm good at it. So I advise all of you to, practice it. It's very easy. There is nothing difficult in this. Then we have called something called as the CR POSSUM, also called as the colorectal POSSUM. It was created in 2004, specifically dedicated for colorectal cancer for predicting mortality accurately. And it is said to have better calibration and discrimination than the POSSUM and the POSSUM, mostly used in the United Kingdom. And as I told you, you can use it for emergency laparotomy and colon cancer resection surgery. So in this POSSUM, again, you have the physiological parameters, including the age, the cardiac status, the systolic blood pressure, the pulse rate, the hemoglobin, the urea. Then we have operative parameters, the operation type, the peritoneal contamination, the malignancy status, and the CPOT, that is elective or emergency. So that was all about the POSSUM, the POSSUM, and the CR POSSUM. Now comes the surgical Apgar score, SAS. It was developed by Atul Gawande in 2007. I'm sure all of you know who is Atul Gawande. Which book has he written? Can anybody put in the chat box? Yes?
Is there a gift for that?
I will have to sponsor the gift now. Yeah. I'll send. Let me know.
Regent, please write. It's a very famous book.
Yeah, none of our pages are reading books. That means they are only, I don't know what, then if they're reading textbooks or they're not reading these books. Yes? Nobody knows the answer.
They have written being mortal. No, it's related to anesthesia actually.
You only tell the answer then.
Checklist.
Please go and read this book, okay? All of you. Okay. So this can be applied, this score can be applied to any patient after the completion of the surgical procedure. Please remember that this is not pre-op, but you apply it after the completion of the surgical procedure. And it will help to identify patients who need intensive post-op monitoring early in the course. So this is nothing but this Atul Gawande's, what is this, the SAS, that is the surgical Apgar score. It is a 10-point risk index based on 3 operative characteristics. What are they? The lowest heart rate during the course of the surgery, lowest heart rate, lowest mean arterial pressure, and the estimated intraoperative blood loss. These are the 3 most important characteristics in this 10-point risk index of the surgical Apgar score. So I'm sure all of you must be telling, no, we know Apgar score, but we don't know what is the surgical Apgar score. So from now you know what is the surgical Apgar score. So please remember that higher the surgical Apgar score, lowers the risk of complications. If the score is more than or equal to 7, consider usual care. If score is less than or equal to 4, please remember there is a high risk of decompensation. So monitor the patient closely in an ICU setting. Very simple score, strong predictive values for post-operative morbidity. It has been validated across multiple institutions and countries. Then we have this ESAS, the Emergency Surgery Acuity Score, quite recently devised in 2016. It includes total of 22 predictors, which include 3 demographic predictors, 10 comorbidities, and 9 laboratory variables. Score ranges from 0 to 29 points. So the score is 22 or greater, the probability of 30-day mortality is 100%. Now, coming to the elderly surgical patient. Now, how are you going to do risk assessment in these patients? See, an ideal predictor in this group of patients should include all the known elder-specific risk factors. And, there are some univariate predictors. So these 5 most commonly identified predictors of risk in the elderly are the age. If the person has already given a do not resuscitate order, the surgical urgency, presence of sarcopenia, that is the loss of muscle mass, and frailty. These are the 5 most common identified predictors of risk in old age, in the elderly. Then there are other predictors like body mass index, preoperative anemia, alcohol abuse, preoperative activities of daily living, and presence of diabetes. Multivariate predictors of risk in elderly includes the ASA physical status classification, but of course, ASA has got some limitations. Then in the elderly, we have got various tools to predict mortality and morbidity. This is the frail index, the frail scale, the modified frailty index, the Edmonton frail scale, and the clinical frailty scale. The components are different in each of these scales and indices. The number of parameters is different, and the clinical outcomes are slightly different as to each index. What does it indicate? What clinical outcome it indicates? So this clinical frailty scale components include presence of comorbidity, function, and cognition. And the score more than equal to 5 is considered to be frail. See, this is the clinical frailty scale. 1, very fit, robust, active, energetic, motivated. 2 is fit. 3, managing well. 4, living with very mild frailty. 5, again, people who, what happens when the elderly person, when he slows down, when he's not able to do his daily activities, he needs help. That means he is becoming frail. Look at this. 7, completely dependent for personal care from whatever cause, physical or cognitive. Now, in the elderly, the problem may be physical. He may not be able to work because of joint problems or something like that, or cognitive. There may be some problem in his cognition. So he is dependent on somebody else. And look at this, 8, he's completely approaching the end of life. He's completely dependent for somebody, even for personal care like bathing and so on. And 9 is, of course, the terminally ill. In such a person, the life expectancy will be less than 6 months. So this is all about frailty. And whenever you examine an old patient, please check for frailty. And if the person is frail, please remember the surgical risk is going to be more. The outcomes are not going to be good in this patient. So just don't go with the chronological age of the patient. If the person is frail, you mention that he is frail, you mention the severity of the degree of the frailty, and then this is how you can predict the outcome. So the risk assessment in geriatric patients, please note the comorbidities in the patient, the functional status and level of independence. They are often on different types of drugs, old people, polymedication, the cognition, depression in the old patient is very common, sensory impairment is very common in them, their nutrition is often very not good, and the presence of frailty, which I have already explained to you. This is a very important index, the Charlson's Comorbidity Index. See, I will show you. This is the various comorbidities which are included in this index, and for this score of 1, 1, 1 for each. Prior MI, heart failure, vascular disease, dementia, COPD, rheumatological disease, liver disease, diabetes, leukemia, lymphoma, metastatic solid tumor, AIDS, and so on. Then we have an age-adjusted Charlson's Comorbidity Index, where according to the age, you add a score. So more than 80 years, you add 4. Less than 50, you keep 0. Then risk assessment in oncosurgeries, we have something called as a PERIDIA score, which is used to assess risk in the perioperative period of cancer patients who are undergoing non-palliative elective surgeries. So this is the PERIDIA score, which includes frailty, the nutritional state, the presence of comorbidity, and the ASA score. So these are the components of the PERIDIA score. Now, we should also know which patient is at a risk of post-operative acute kidney injury. We always think of post-operative pulmonary complications, but how many of us think about post-operative acute kidney injury? Do you ever ask yourself, is this patient at a risk of developing kidney injury? Well, old age, obesity, urea creatinine ratio, more than 20, pre-op hemoglobin if it is low, if there is a decrease in the perioperative hemoglobin, a low preoperative serum albumin, which I've already told you about, patient is on AC inhibitor or angiotensin receptor blocker, or if a large intraoperative colloid infusion is given, please remember that the risk of post-operative acute kidney injury is high in these particular patients, and you should watch out for that. Now, a word about the obstetric patients. There are some risk assessment tools for severe postpartum hemorrhage in women undergoing cesarean delivery. These are the California Maternal Quality Care Collaborative, commonly called as the CMQCC, the Association of Women's Health Obstetric and Neonatal Nurses tool, and the New York Safety Bundle for Obstetric Hemorrhage. So we will not go into all these, but they have tried to compare these 3 scores, and depending upon various parameters, and especially the obesity and the presence of thrombocytopenia, because you know that both obesity and thrombocytopenia, the incidence of PPH is very high. So there is this study which has evaluated these 3 tools, and they have found that these tools have moderate prediction to identify high-risk groups at risk for severe postpartum hemorrhage after cesarean delivery. And in one study, in a recent study, it was found that this California tool is most specific, and this American nurses tool is most sensitive. Now, in pregnancy, you often get cardiac disease in pregnancy, right? So risk stratification here can be done by the CARPREG score. Presence of prior cardiac event, 1 point, like heart failure, TIA, cerebrovascular accident, or arrhythmia. NYHA class 2 or cyanosis is 1 point. Mitral valve area less than 2 square centimeters is 1 point. Left ventricular outflow tract gradient more than 30 is 1 point, and ejection fraction less than 40 is again 1 point. So they say that CARPREG point 0, 5% cardiac complication rate, 2 is 75%. So if you have a patient with pregnancy with heart disease, you can calculate the score. So I think pregnancy with heart disease comes as a long case in the exam. So if you apply the score, examiner will be happy, I suppose. So this is an example I'm giving you, exercise for you people, mental exercise. A 32-year-old second gravida, para 2 living 1 with history of breathlessness on moderate activity and no other symptoms, with echocardiography showing mitral valve area 1.5 square centimeters and ejection fraction 35%. Please calculate the CARPREG score. At least you should give an answer for this. It's a very simple score. Mitral valve area 1.5 square centimeters, ejection fraction 35%. Please calculate the Carr-Preg score. I'm putting once more here the points for you.
Ma'am, we have 2 more minutes.
Okay, done. I'm done with it. Answer is 2. So there are various risk factors in the pediatric age group also. Like, perioperative respiratory adverse events are common in this age group and they lead to cardiac arrest in children. So these risk factors for the perioperative adverse respiratory events include child-specific risk factors like age less than 6 years or infants below 1 year. If the baby has clinical signs of URTI, and if the parent says that the child has a cold and passive smoke exposure. Anesthesia-specific factors like instrumental manipulation of the airway management with an endotracheal tube is more risky for airway events than that with an LMA and then with a face mask. Desflurane, more risk of adverse events than sevoflurane and propofol. Surgery-specific risk like ENT surgery, eye surgery, airway surgery, upper abdominal surgery, cardiac surgery, more risk of airway events. So if in the preoperative airway assessment, if the baby has fever and malaise with a running nose, then it is severe cold. If it is running nose, moist cough with purulent congestion, it is moderate cold. And if it is just watery congestion with running nose and dry cough, it is mild cold. So many times you tell that the patient is having a running nose. So how do you evaluate such a patient? So if it is mild cold, you can just treat with bronchodilator and proceed with the management and try to avoid intubation, desflurane, try to use LMA, propofol. If it is moderate cold, try to weigh the benefit against the risk. If it is severe cold, postpone the surgery by more than equal to 2 weeks. So this is a cold score. C stands for current signs and symptoms, O for onset of symptoms, L for lung disease, D for device, airway device to be used, and S for surgery type. So this is a cold score. So example, a 6-year-old child with intersusception is got rhinorrhea, cough with expectoration, with congenital cleft palate. What is the cold score? None of you are answering in my time. I'm running short of time. So what should I do? I will come out with the answer myself. Anybody with the answer?
Dr. Madhuri, you give the answer yourself. Time is running short.
Okay. The patient complains of rhinorrhea and cough. But here I would like to know what is the nature. A question which I would ask is, what is the nature of the, the secretions? Is it purulent? Is it watery? Does the patient have fever? All these questions I will have to ask and then I will grade the patient. So you also have a risk score where prediction score to predict post-operative ICU admission in children, which includes all these variables. You can go through this. And there is risk stratification in cardiac surgery also. Parsonage score is used. You can go and read this. What is the Parsonage score? Especially it is used for the outcomes after CABG surgery. This was another example which I had put. If you want, I can send it to you afterwards. And there are various such risk scores. There is no, dearth of scores now. So to summarize, what is the current status of risk stratification? You will ask me that there are so many scores you have told us. So what are we supposed to do? Well, the ASA physical status classification, functional capacity by METS, cardiac risk by the revised cardiac risk index, looking for frailty, comorbidities. These are very, very important risk predictors and you should use these in your daily practice. RCRI and the American College of Surgeons NSQIP, they are considered complementary while assessing post-op cardiovascular risk. ACS NSQIP risk calculators are most often used in the USA. They are freely available on the web but require internet connectivity. CPIT is used in selected high-risk patients in the United Kingdom. Biomarkers, they can be used in patients with reverse cardiac risk index more than 1, patients with age more than 65 years. And POSSUM scoring is being used in the United Kingdom. And the American Heart Association suggests CPET, that is cardiopulmonary exercise testing in patients with unknown functional capacity undergoing high-risk procedures. So there are areas of future research in this topic, like the impact of genotype on perioperative outcome and risk, and so many automated risk calculators I told you, but research has to take place on all these risk calculators. So next time you take a topic for dissertation, you can probably take such topics. So identification of the high-risk surgical patient is a very complex job. It depends on interaction between surgical, anesthetic, and patient risk factors. There is validated indices, biomarkers, and intraoperative hemodynamics, which can help you. Artificial intelligence and machine learning have helped produce automated risk calculators. But please remember that the risk calculators can be used as adjuncts to clinical decision making. And remember that nothing can substitute clinical decision making. Please remember this sentence, that nothing can substitute clinical decision making. So be brave, take risk, but nothing can substitute experience. Thank you very much.
Such an extensive presentation, ma'am. And I request Dr. Amita Rani to kindly sum up the session.
एक्सपेक्ट कर रहे थे आप? 2 लाख बोलना.
Thank you very much.
गाड़ी के
Dr. Indrani, you start. Dr. Amita may not be able to connect.
Okay.
Hello.
Yeah, Amuda's talking. Yeah. Okay.
Yeah.
Good evening, everyone. Excellent, and what an elaborate presentation. Madhuri, your PowerPoint presentation was fantastic.
Thank you, madam. Thank you so much.
It's very extensive. Very good session. It's what a session to start with. It's very actually impressive. I have to thank the president and the secretary for this opportunity to chair this session with Dr. Indrani madam. Thank you so much. I checked the chat box. There was no questions till now. I think nobody has raised any question because of your elaborative and extensive narration about the risk of anesthesia. So you have summarized. I think I will tell you. So for the postgraduates, few mantras of anesthesiologists, which will help to identify and manage the high risk surgery patients. First one is proper and thorough preoperative evaluation with adequate and appropriate investigations, optimization of patients, meticulous preparation of patients, preparation of theaters, and required equipments, gadgets, and drugs. Prior planning of anesthesia techniques, preoperative discussion with surgeons about surgery and anesthetic plan, and mainly about the surgery and anesthesia. We will work out all the logistics outstanding with, good rapport with the surgeons. Finally, identify a person of our profession or our colleagues for support beforehand itself to tackle any preoperative untoward events. Never ever forget our motto, eternal vigilance. It is a most effective tool which will help us to prevent 99% of perioperative risk. Mainly, it reduces mortality, morbidity, thereby helps in reducing the hospital stay, hospital costs, at the same time leading on to better outcome. I thank everybody. Best wishes for the new team to continue the consistency of the previous team of the president and secretary who has done this, embarked this program in a very passionate way. Thank you. Long live ISA.
We invite the audience to ask their questions and interact with the speaker and the chairpersons. They can unmute themselves.
In the meanwhile, some inputs from Dr. Indrani madam also.
Yeah, so very exhaustive and excellent presentation. I think every student should know this, and very importantly, what I feel is when you come to do, practically when you're dealing with the patient, the functional assessment should be given more importance, especially, all the cardiopulmonary exercise testing or METs and things like that. Those have got more importance than just the history. And one question I had for you, Madhuri,
Yes,
about
please.
acute kidney injury.
Yeah.
I was quite surprised that that it didn't include uncontrolled diabetes or uncontrolled hypertension, because the major killer in acute kidney failure is diabetes,
Yes.
uncontrolled diabetes. So basically but that is not seen in that
Yes.
index.
Yes. You're right, madam. Diabetes and hypertension, they
Both
should,
are not there.
they
Yeah.
should be included in that, right?
Yes.
Yeah.
I was like
Yes.
surprised about that.
Yes. Yes.
Right.
But every patient we come, we should think whether this patient is going to develop post-operative pulmonary complications and the risk of acute kidney injury. These two things we should think when we start the case.
Right. And I think even intraoperative hemodynamic parameters play a very big role. Not only use of colloids, but intraoperative hemodynamic parameters also play a big role in acute kidney injury.
Yes. Especially the mean arterial pressures.
Yes.
Yes.
Very rightly said, ma'am.
Yes, madam.
Very rightly said, because despite so many scorings and all, which can be done, because we can do the scoring to know the exact thing, but in a clinical setup, when we have like we are busy with our pre-anesthesia clinic with so much of rush, and also though we review the patients in the OT or one day prior to OT, your clinical judgment is also equally more important. The risk scoring is of help to know the exact, yes, the perioperative assessment and the mortality or possibility of a morbidity in the patient. So the judgment, clinical judgment is equally important. That is why I said that what Madam Amrita and Madam Hemant have said is very right. So theoretically, these things are known, because PGs are expected to know these scorings and all. Assess, they, like you said, in a pregnant patient, assessment can be done, and then it can be, scoring can also be done. Though we talk about mitral stenosis in pregnancy, and clinical discussion is very different. But yes, if they know these scores, postgraduates, they score better and they can show their knowledge on these aspects. Thank you.
Yeah, and more often the good part is we are doing more of 2D echo. When we were students, 2D echo was only asked by cardiologists, none other.
Yes.
So now we are doing it and we are evaluating ourselves. We are putting in the echo probe and trying to evaluate it all by ourselves. So that's the biggest leap. I mean, another big leap in our, in anesthesiology. But what, again, from what you said about biomarkers, we have not yet reached there. We still don't ask for, biomarkers, wherein biomarkers are very, very important to understand what could be the risk for that patient.
Not as a pre-operative assessment, but like if there is an event or something.
In the ICU, yes, but
yes,
not in
ICU,
the
especially
we are not,
troponin
we are not
only in critical care setup it is done, madam.
Yes, not in the pre-op period.
We are not asking.
It is not
But it
for
will make a very
rightly
big impact on the assessment of the patient.
Yes, madam rightly said 2D echo. Even if when we are not doing, we ask for it. And it is a very helpful tool in a patient who is a diabetic, hypertensive. We get to know a lot about their cardiac status, not on about the functional status. That is what we want to know.
That was really a good discussion. I think the postgraduate students, when they see the discussion among the teachers, it's always very helpful, because so many teachers, all the renowned teachers sitting together and discussing for their benefit. I think this is something, a very, very useful platform for them. And the person who started this program, Dr. Naveen, he's also there. I would like to ask him certain things. Sir, I want to know certain things which we should be doing as going from the platform which you have already created, how to go for further. And I think this is the first class, and how you are feeling. Your words, please.
It's always said, well begun is half done. So half the job is done, and really congratulations to you that you have picked up from where we left. These classes, when they were started on 1st of July 2021, they have been a runaway hit since then. and the postgraduates have really liked them. And these classes, because if suppose somebody is missing today, they will go to ISA website in the ISA academics tab or to the ISA YouTube channel, ISA NHQ. The recordings are visible and they can view at their leisure time also. And heartiest congratulations to Dr. Madhuri Kurdi for an excellent and exhaustive scoring. What I wish is, please take a thread from her talk today and start implementing any of the score of your choice as per your institute or department protocol and according to the surgical substrata. And ably guided by Dr. Amutarani and one of the previous speakers also, Dr. Indrani Hemant Kumar, who has taken the one of the past ISA online classes. And I'm very sure that students will be benefited in near future continuously without any break for the learning from esteemed teachers and getting pearls of wisdom from esteemed chairpersons and the interactive audience. And I also wish to compliment the coordinators. We started with Nishant and then our family grew up, and Jyotsna and Monica and Ankur and others pitched in, and Parul, and they are coordinating well with the teachers. So best wishes, and I look forward to continuous learning myself also. All the best.
Thank you, sir.
Thank you, sir.
Excellent presentation. The content was so good that, you know,
Yes.
many of the students are asking for the PDF. So,
Yes.
so
I
the
have got- I
IDA
already seen
editor,
2 to
please listen to this. Maybe
Madam,
we should have a
the recordings are available, madam. They are
YouTube.
available online, free of cost. So I think the students should at least visit the YouTube channel or website and learn from them.
Also,
That's up to you, sir, for this
Naveen
platform.
Malhotra, sir, I wanted to tell you that I've listened to so many students who say that they go and before their case presentation, they go to this ISA YouTube channel and they listen to the entire case presentation, and then they go and present in their respective colleges, and they have benefited enormously. And thank you so much for starting this for the sake of students. The students are benefiting a lot.
More importantly, Dr. Bajwa is continuing with full zeal and fervor, and will take it to newer heights with new innovative ideas like this change of time, and it will make me more proud.
I'm sure about that. Dr. Bajwa is full of energy, and we can be rest assured that the post is on very good shoulders.
Thank you, ma'am. Thank you for that. I really appreciate everybody listened. And from next class onward, we will have certain codes of conduct also regarding the muting of the audience, whereas because the speakers get distracted. So few things we will continue. The improvements will continue in the coming days also, because as we progress, so we will be knowing our faults, our weaknesses, also our limitations. So we will work upon them. And more importantly, the next class is, I think Dr. Indrani told about the intraoperative hemodynamics causing a lot of disturbance in the renal functions and even in the other organs also. So we will be deliberating upon perioperative fluid therapy in pediatric population in the next class. At the same time, we will be starting at 6:30. I have already asked all the PG students, they can send a mail to isanhq@gmail.com if they want any other suitable time for their classes, because we want their participation. It is important for them. We can adjust our timing to some extent. So just is a suggestion to them that they can always decide among themselves. They can send a mail to us and we will work upon that, because there were some feedbacks that regarding 5 o'clock, the timing was little bit earlier because they were doing the pre-anesthetic checkup. They were going home from the colleges or the institutions. So I think they wanted another 1 to 1.5 hours for the relaxation before they can start a class. So everything rest is available on the website. I think everybody should visit the ISA website now. It is full of so much of academic things and other programs. And I think our coordinators, they are doing a good job. And Dr. Naveen rightly said that this team has to grow further. and we will definitely grow further with the improvement in the further teaching methods also, because every day newer learning methods are coming into the, I think globally they are growing. So we will be adopting those techniques and technologies also in the coming time. For the time, I think I must say a very, very heartfelt thanks to Dr. Madhuri for who has done a wonderful job. And I think she has allowed the participants to answer also. That was a wonderful idea.
Thank
So
you.
I think in the coming days also, we will be going with these type of programs. And apart from the online PG classes, there will be some more programs will be coming academically. We will be involving our postgraduate, senior resident, especially the Yuva work we will involve, and with the in participation of our senior teachers and all those colleagues also. So I'm really thankful to everybody who has participated in this class. And next Monday, we will be meeting again with the class on the perioperative fluid therapy in the pediatrics. Thank you, everyone.
Dr. Rekha wants to make a point.
Yeah.
Dr. Rekha Das, unmute please. Dr. Rekha Das,
Yes,
unmute.
sir. So I would just like to congratulate Dr. Madhuri for an excellent presentation.
Thank
And
you.
it is really so nice. I kept on hearing you throughout the talk, and it was so useful for my postgraduate. I got my first batch of postgraduate students, and they were keenly hearing your talks. And I'm sure it is a very good lesson take home for everyone. And I must also congratulate Dr. Naveen Malhotra for setting such a landmark benchmark, and Dr. Bajwa for taking it to a very good height. And I am sure the ISA will do great wonders as regard this academic curriculum. Congratulations to the team once again from the bottom of my heart.
Thank you, ma'am. Thank you very much, ma'am.
Thank you.
So with all this, I think it's a time to say it's almost around 8, going to be 8:30. We should be saying goodbye to each and everyone to meet again on the next Monday at 6:30 p.m. So good night from the ISA headquarters.
In advance, Happy New Year to all.
Happy New Year to all. It's the last class of the year, and it's a combined transition phase. It's a common working day between the past secretary and the present secretary.
Yeah.
The common working class. So good night to
Wish you all
everybody.
Happy New Year, sir.
Happy New Year. Happy New Year to everyone.
Happy New Year.
Happy New Year.
Happy New Year to everyone.
Good night to all. Good
Thank
night,
you.
Indrani ma'am.
Good night.
Good night.
Good night. Good night.
Good night. Good night.